cause this debilitating disease, scarlet fever, acute pulmonary nephritis, rheumatoid arthritis, rheumatic fever, and acute epicarditis. And you have to make sure that it's correct. And which one is the one that's correct? Rheumatoid arthritis. Okay? Good? Questions? So I've got a bunch of stuff here for that, and I'm just not going to talk about it because I've given you the skinny, and the skinny is all I'm going to test you over. Okay? Otitis media is the bread and butter of all general practitioners. Lots of kiddos get it. Bree's probably going to tell me I've never had a tympanic membrane infection. I've never had an earache ever. Look at that. So 85% of all kids pick them up. That's very common. I can remember going swimming in a creek or a lake or a river, and then after we finished swimming as kids, we would be lined up, and my aunt would put gentian violet into our ears, right? And so that was to remove the water and then coat it so that it would give up ear infection. That's very, very common in kiddos. This is a normal tympanic membrane, a normal eardrum. This is when it's inflamed. And so it can get worse. So here you can see the cerumen is actually produced by the flushing mechanism, and you can see the pus and things like that. Now, if you irrigate this here with warm soapy water, it'll pull a lot of the stuff out. And it'll alleviate some of the pressure, but it's not going to take care of the infection. You're going to have to be treated with antibiotics. And if it's a kiddo and they've developed several different ear infections over the course of like 4 months, the way that we remedy this is to put tubes in the ear. We put tubes in the ear and it goes away, right? Because there's a lot of drug resistance to the organisms that are causing middle ear infections. Otitis media is middle ear infections. Otitis externa is outer ear infections. And otitis interna are inner ear infections. Be sure you can distinguish the difference, okay? So with kiddos, a lot of times the really young ones can't tell you my ears hurt, but they'll show you some signs of it. They'll be tugging at their ears. They might have a low-grade fever. They might be real irritable, right? We would say they're fussy. But one of the ways we check for it is we have the parent get the attention of the child, and then with a clicker. Does everybody know what a clicker is? It makes a distinct noise. They use it to train dogs. Back in my day, we used to have noisemakers during Halloween, and we would be clicking down the hall, telling the people we're arriving, get ready to give us some treats or trick us, because some people try to trick us. But I have some of those because Halloween's my favorite of all holidays, and I collect a lot of crazy things from old Halloween stuff, right? And so it's pretty interesting. If you don't have a clicker, what you can do is come to the back of the head of the child and snap your fingers. And so you want them to be able to respond to that. But if they don't respond to that, then you know that something might be wrong with their hearing. And these things can lead to all kinds of problems with speech development. Because when we talk, we will mimic the individuals that we live with. Right? And so if you have a very southern accent, the reason that you develop that southern accent is because you grew up with a bunch of southern people, right? If you develop a Bostonian accent, I'm gonna go to the pie, I'm gonna have a little fun at the party, then the reason that you have developed that is because those are the individuals that you hung out with. And so that's why we have all these inflections of languages. In Texas, we have a whole bunch of them. You go to South Texas, it's a different inflection than there. You go to East Texas, it's twangy over there. How y'all doing over there? And if you go to West Texas, it's drawn out draws that talk like that, kind of over there. Are you with me? Yeah. And so we have lots of different inflections, but the reason that those are is because of the fact that we mimic the sounds that we hear. And sometimes little kids like the way certain words sound when they come up, right? So you think about S-H-I-T, I'm not going to say it, but shoot, right? And so shoot, and so the parents will stub their tongue out, shoot, and they'll be saying that kind of word. Well, then at church one day, everybody's real quiet, and all of a sudden a little kid will go, shoot, and I say everybody laughs, right? Because it's so innocent. They don't know what they're saying. They're just using the word because they're mimicking their parents or their siblings or whoever it is they do that, right? And so it's pretty interesting to think about. But a lot of times that can lead to a lot of difference in the way people talk and the way they enunciate because they haven't heard the words probably correctly, right? And so instead of saying Corey, they'll say Chloe, right? And so they'll have these different ways of speaking because they had problems early on in their development of their speech, okay? So if I'm here in Texas, people will tell me I don't have a Latino accent. But if I go to Pennsylvania, they're like, you're Mexican, aren't you? I'm like, yeah, because you have a really strong accent. I'm talking the same, but it depends on where you're at. People can pick up the inflection or not, right? And so it's pretty interesting to think about. What we do know is that if children grow up in a household that smokes, they're much more apt to develop ear infections than those that are brought up in homes that don't smoke. The other thing we know is that if you are an infant and you're drinking out of a bottle, if they lay you on the side, sometimes some of that nutrient can come back into the eustachian tubes and then cause an infection back there because it's just a bunch of nutrients, right? And then we know that decongestants or antihistamines, if you take those, they'll alleviate the symptomology, but they're not going to solve the problem. The problem is an ear infection. And so you have to take antibiotics to clear it, or if it's one of those things that is chronic, you're having it a lot, then you put tubes in the ear and it goes away. Yeah.
My mom used to just put breast milk in her ears.
So what, your mom used to what?
Put breast milk when we had an ear infection.
That's an old folk thing. I don't know that it works.
It worked for me. She's gonna work for me.
That's the same thing with one of my students one time said, yeah, what we do is we take a baby's diaper and we clean our face with the urine. I'm like, I've never heard about that one. I've never heard about that one. She goes, oh yeah, we do it all the time. I'm like, okay. If you don't have a baby, where do you get the urine? That was my question. So, if we think about this, the organisms that cause middle ear infections, here's some of them. You don't have to know this pie chart. You don't even know percentages. So it's Staphylococcus aureus, Pseudomonas aeruginosa, Proteus mirabilis, Streptococcus pyogenes, Escherichia coli, and Haemophilus influenzae. The other one that's made big headlines lately is because of all the drug resistance is the Enterococcus, the group D Enterococcus. They are problematic, right? And so if I asked you on an exam of the primary pathogen that causes middle ear infections, it's going to be Enterococcus. Okay? Write it down.
Say it again.
The primary pathogen that causes ear infections that are hard to treat is Enterococcus because of the drug resistance it causes. Okay? Questions? Okay. Here's Haemophilus influenzae. Haemophilus influenzae is a small gram-negative coccobacilli. And there are some aggressive forms that can cause all kinds of problems, right? So they can cause blood infections, they can cause ear infections, they can cause pharyngitis, all kinds of different problems, right? It used to be a really big problem, and then we started giving the Hib vaccine. So the Hib vaccine stands for Haemophilus influenzae type B. That's what it stands for. And I think that's one of the ones you have to get for nursing school, is that correct? You don't know? Okay, I'm not sure. I think it is. Who knows? There's quite a few. The organism is a mesophile. It grows best at temperatures between 35 and 37. Our body's perfect for that. And so here are the different infections like pneumonia, otitis media, epiglottitis, eye infection, bloodstream infection, and meningitis. Right? It can also cause cellulitis, but it's fairly rare. We're more likely going to see it in the back of the throat. Okay? Good. And then diphtheria. So diphtheria is an infectious agent that we have not seen in the United States for over 50 years. The reason we haven't seen it is because we have really good vaccinations and they have kept it down. In other countries, we still do see diphtheria. Are you aware if it's still in India or not?
Not sure.
Okay. My chart says it is, but I'm not sure if it is or not. I might have to change my chart out. But I do know in certain places like Russia, They don't share information with us. We don't know how much is there. But we've had researchers go over there and say it's still a problem. Right? And the reason it hasn't been a problem in the United States is because of the vaccine programs. The organism is a gram-positive organism. It's pleomorphic, right? It's non-modal, and it doesn't produce any spores. And so this is what it looks. It has a lot of different shapes, right? So when you first see it, you're not sure if it's a coccus or a rod. You do a little bit more work with it, and you find out that it's more rod-like than it is coccus-like. But it tends to show up with these different shapes. So it's an indication of what it might be. It has two different presentations. It can show up cutaneously, very rare, but it also, in other places, not the United States, it shows up as an infection of the back of the throat. Okay? And not only that, but there's some different characteristics here where we start, do you see this back here? That's a pseudomembrane. So we start to have this pseudomembrane form, and the pseudomembrane is hard and it's attached to the tissue at the back of the throat. And it's composed of dead epithelial cells, white blood cells, red blood cells, the bacterium, right? And this thing gets really hard, and if you try to touch it to culture it, just by touching it makes it bleed and it's painful. Okay? That's called a pseudomembrane. And here it is again, you can look at it in the back, you can see. Symptoms are, does everybody know what these are? Right? These are things that are commonly used, so you have symptomology, treatment, diagnosis, and prescription. There's another one that's not up here, right? So it is this one, which is prognosis, right? So you have all these different things that are used in medicine, right? You might as well get used to seeing it now. Okay? Now, if we think about it, we have molecular techniques in the United States, so if we ever had a case of diphtheria that needed to be worked up, we would just take a little bit of swabbing from the back of the throat, we would use that, and we would look for an antibody test or a gene probe test that would tell us immediately what it was. Some places in the world don't have access to those types of tests, so you can use an old-fashioned test. This still works today. It's called an elite plate. And here what you do is you take a piece of filter paper. It can be coffee filter. It doesn't have to be anything special. And what you do is you impregnate the actual filter paper with the antitoxin, the cytotoxin that's produced by Corynebacterium diphtheria. And then you take the suspect cultures that you took from people's back of the throat, and you just streak them across the plate. And where those things are growing, if they produce the toxins are going to be diffused into the media, along with the antitoxin that's going to diffuse out of the filter paper, and you're going to develop these precipitation lines where you're going to have an antibody-antigen reaction. We call those things whiskas because they look like cat whiskers. But those are positive indication in places in the world where they don't have a lot of resources where they can look for Corynebacterium diphtheria. Okay? Any questions? So the etiology of diphtheria is what? Corynebacterium diphtheria. That's kind of the answers on the test. Right? So the other thing you really need to know is that in order for somebody to develop diphtheria, the organism has to be in the back of the throat. It has to be infected by a bacteriophage. The bacteriophage has to transform the organism so that it produces a cytotoxin, which then leads to the symptomology of diphtheria. That's a lot of words. What did I just say, Nikki? In common names, in common words.
You have to have the toxin in the back of the throat.
Not the toxin, the bacterium.
Oh, sorry, the bacterium. And then
It has to be infected by a virus. The virus has to inject its DNA into the bacterium. It becomes transposonic. It becomes part of the DNA of the bacterium, and it changes the bacterium, so now the bacterium produces a toxin. Yeah. That will be a question on the exam. I love that question. Okay? Know it. I'm giving you the other half of the exam, and you're going to write the other half. You should do really well. Okay? Y'all are not very excited. Y'all are like,
I felt so fast. I'm like, they're in Mrs. Fox.
His room is recording me. And another recording is on my YouTube channel. You can listen to that. I think every single lecture from this unit is on YouTube. You can pick them up if That doesn't mean, Ms. Brito, that you should just skip the rest of the semester. Right? Even though you're done with lab, or will be done with lab pretty quickly. So the prevention these days is still vaccinations. It's the DTaP. The DTaP stands for diphtheria, tetanus, and the acellular form of pertussis. If you don't want to get them all three, you can get them the D by itself, the T by itself, and the P by itself. You can get diphtheria, tetanus, and pertussis all individually if you want to. I don't see any reason, just lump them together, green, let me have it. Good? One time I was in a doctor's office and I don't know, I cut myself in the yard. He said, well, when did that happen? I'm like, a day ago. He goes, well, I think we should just go ahead and give you a tetanus shot. I'm like, okay. Then he came back later and he said, I'm out of tetanus toxoid vaccines. Will you take the DPT? I'm like, yeah, just give it to me. So I got protected for 3 organisms in 1. So I like that. It's pretty good. This is Balto. Who knows who Balto is? I love Balto. The story of Balto.
I've been there.
Oh, have you? You've been there?
Yeah, I have a picture by the statue.
Oh, yeah,
No,
so
no,
this
I've
is
been
in
to
Washington,
Alaska,
Washington.
just Washington, in New York.
So, the story of Balto is in the late 50s, early 60s, there was a big outbreak of pertussis. Some people say diphtheria also, pertussis, in Nome, Alaska. The problem is there's this big old blizzard and they ran out of vaccines and they ran out of anything that helps. At those cases, it was sulfur drugs. They ran out of everything. And people were really sick and they were afraid they were going to die. The only way they could get to Anchorage to get relief was by dog sled. So Balto represents the dogs in those teams of dog sleds that went from Nome, Alaska to Anchorage, pick up supplies, and then went back and saved a lot of people's lives. There's a cute little movie about it. It's very cute, but you can read about. It's historical. Now Balto, there's some kind of debate whether or not Balto should be used because there's another dog that was a lead dog, and it just didn't have a name Balto that was kind of cute and marketable. So I think they started using Balto just because it was easy. But this other, I don't know what this other dog's name is, but they want to try to bring that back, and I don't know if they're going to ever do it or not. But it's pretty interesting to think about. We do a lot of things that you all don't know about have their origins in microbiology. There's artwork, there's songs, there is movies, there is races, there's all kinds of things that have their beginnings in microbiology. There's a famous race that happens in January every year from Nome, Alaska to Anchorage and back, and it's called the Iditarod. And the Iditarod, we're paying honor to Balto and the dog sleds who saved a lot of people's lives, right? But that has its roots in microbiology. People just don't ever think about it the same way I do. That's pretty interesting to think about. Okay. Anybody have any questions? Those are all the upper respiratory tract infections. We're about to go into lower respiratory tract infections. Okay. Good. Here we go. So, when we talk about lower respiratory tract infections, we're mostly going to talk about pneumonia, whooping cough, and tuberculosis. And there's a lot of forms of pneumonia. Right? So pneumonia is a catch-all phrase. Pneumonia means that there's inflammation of the lungs and fluid buildup in the lungs. That's what it means. Okay? You can get pneumonia from different etiologies. It can be infectious agents. It can be chemicals that you come in contact with that destroy the tissues, which leads to inflammation and the formation of fluid. And also you can have things like allergies to it also. So write this down, the number one cause of pneumonia in us are viruses. However, if we just know that fact, which it might be a question on the exam, excuse me 1 second, I'm about to sneeze.
Bless you.
If we just take that one piece of information, then most of pneumonia is actually caused by viruses, and just look at bacteria. The number one cause of bacterial pneumonia is by far Streptococcus pneumoniae. Not only that, but write this down also. Streptococcus pneumoniae is the leading cause of pneumonia in adults and the leading cause of meningitis in adults. Okay? Those are two major infections. Right. So Streptococcus pneumonia is the leading cause of bacterial pneumonia and bacterial meningitis. Okay? And so how easy is it to get pneumonia or meningitis from somebody else?
Easy.
Easy. Breathe it in, touch somebody, and then touch your mouth, and it goes crazy. This is known as a triangle of concern. Because if you get an infection in any place here, it can move back to the meninges into the brain and cause meningitis or encephalitis. People don't think about it like I do. Right? That's why we should take pneumonia very seriously, especially for the elderly and the immunocompromised. Okay? So, you can see that if we look at the leading cause of pneumonia, bacterial pneumonia in adults, by far, it's Streptococcus pneumonia. 90% of all cases of bacterial pneumonia are going to be Streptococcus pneumonia. Remember, the bacteria are in charge. They cause most of the problems in a hospital. But the viruses are in charge if you're in public. All right? So it's really important you understand that. So if we think about the organism, it's gram-positive diplotoxin. It's heavily encapsulated. This is the mucoid form. The one that we use in the lab was kind of a rough-looking dude, and it's not very dangerous, right? This organism is dangerous if it's in your body, but it's fragile if it gets out of your body. If you have a hacking cough and you hack up some stuff and you throw it on the ground, spit it on the ground, as soon as it dries, the organism dies. It doesn't survive. It's not like tuberculosis. Tuberculosis, you hack it up, you throw it on the ground, it stays there for a long time. As a matter of fact, tuberculosis, we'll talk about it a little bit, it used to be called an infectious disease of the dusty trades, because people who were working in shipyards or whatever had all this dust around, and they would walk around, like people have TB, and they would spit on the ground, and then they would walk around, and all this dry dust blow into the air, and then people would get tuberculosis that way. So it's important that we understand that. It's alpha hemolytic, it's real easy to diagnose. You can't do a quick test on it because it has a capsule, so there's no way to get to the actual proteins that are on the surface of the plasma membrane. So we do a 4-quadrant streak for isolation, we stick a P-disc on it, and away we go. Okay? So here you can see is the capsule, right? Heavily encapsulated. Hey, Norma, what are these? These are white blood cells. What kind of white blood cells show up in your bacteria present? Starts with N. Neutrophils. Right. So you can see the symptoms: high fever, difficulty breathing, chest pain, and the exudate, the sputum that comes out of the lungs, can have a pinkish or a reddish hue to it, and that's because of the blood that is being released, because of the blood that's being released through the capillaries that are being damaged in the lung tissue. Okay. Here is lungs. And these are, they got some infiltration, right? The darker the lungs are, the healthier they are. I'll show you some in a minute that are just completely infiltrated. And so it shows up as very cloudy or gray looking lungs back, okay? So you can see that there are some individuals who are more susceptible to infections of bacteria that cause pneumonia, Streptococcus pneumonia, but others, right? And they are alcoholics, right? Because if you're an alcoholic, you drink alcohol, and it suppresses the immune response, and you're more likely to develop bacterial infection. Right? The individuals who are immunocompromised, they have AIDS, or they're taking anti-inflammatory or anti-phagocytic, the bunch of different drugs that are inhibitory to the immune system, right? And then that makes them immunocompromised. Also autoimmune diseases, right? So it's pretty interesting to think about how those particular types of drugs can lead to infections of these types of organisms. And the last group of individuals are the debilitated individuals, those who live a sedentary lifestyle or morbidly obese, and so it's important that we just don't stick an elderly patient in the bed and don't go and try to get them up and move them around. Right? because they'll then start to develop pneumonia. Now, you can't get pneumonia if nobody else is around that can give it to you. It's just not going to magically appear out of the air. You have to have contact with somebody who has it. Okay? Good? Anybody have questions? So, it's easy to diagnose. You take a blood plate, you do a 4-quadrant streak of isolation, you put a P disc on it, you come back later, you see alpha hemolytic organism, sensitive to off-filling, and streptococcus pneumonia. The organism is treated with amoxicillin. It's a drug of choice. It'll take them out. All the streptococci, with the exception of enterococcus, have not developed a lot of drug resistance. They don't have the mechanisms to do so. Enterococcus is different. Okay? Good? Now, there are some other etiologies that we need to make mention. Klebsiella pneumoniae is another infectious agent that will cause pneumonia, but this bacterium is much more dangerous, much more destructive than streptococcus. But it typically causes infections in individuals who are alcoholics or the homeless population. There are some really, really resistant strains like carbendazole-resistant Klebsiella pneumoniae, CRKP. It almost sounds like a radio station, CRKP, right? But that stands for carbapenem-resistant Klebsiella pneumoniae, and I will show it to you when we talk about systemic infections. Right? But it is a problem. The other one is Haemophilus influenzae, which we used to see in kiddos when we started giving the Hib vaccine, and the problem seems to have gone away. Now, it's still there in very low numbers, but it's not like we used to see it before. Okay? And then we have Mycoplasma pneumonia, which causes a mild form of pneumonia, but mild form of anything that interferes with the uptake of gases to our body is detrimental. Here's the difference. Mycoplasma pneumonia does not have a cell wall. So it attaches very flatly to the tissues, and therefore it's hard to get rid of. A lot of the damage that happens to the lungs is because of the cell-mediated immune response trying to kill the organism that's attacking the lung tissue itself. Here's the other big difference. Because it doesn't have a cell wall, what's the drug of choice we give to most patients that have a strep pneumo infection? Penicillin. You should know that pretty well. If it doesn't have a cell wall, penicillin is not correct. So if you take a loved one to the hospital and they do a radiograph and they say the patient has bacterial pneumonia, but they don't do any further workup, and they want to give augmentin or some other type of penicillin, very nicely ask if you can have erythromycin instead, because erythromycin will cover all of the pathogens that cause bacterial pneumonia. Okay? Anybody have questions? Legionnaire's disease is a form of pneumonia. This is caused by Legionella pneumophila. So there was an outbreak in around 1976 or so, 73 years around there, at the Belfield Stratford Hotel in Philly. Now, there was a fever of unknown origin, and that's what we call things that we don't know what's caused. There was a fever of unknown origin, and it was causing people to get an infection who not only were there for a convention, the French Legionnaire's Convention, that's how it gets its name, Legionnaire's disease, but also the staff, the people who were working as custodial support, all people who were working, lots of different people. There were over 221 people who came down with the infection. 34 people died of a fever by night. That's never good. So at this point, we knew it wasn't protozoal, we knew it wasn't a yeast, it was a bacterium or a virus, we didn't know what it was. So people started taking samples, and all the samples came back and nothing was growing. So then we had a lab technician who went in and this is an old-fashioned water tower for HVAC systems. It's what cools the air so that you get cold air coming into your, nowadays the systems are a lot different. You have a condenser, they have lots of different things. You don't have these old-fashioned ones. But what happens with this is the water has activated charcoal in it to keep it as clean as possible, because when you have an air conditioning unit, If you just hold your hand up to the air conditioning, it's gonna feel moist because that's moist air coming out. So here, the organism likes water, and it grew in the water, and then when it was put into the HVAC, when it was in the HVAC system, and it was blowing cold air into the building, Legionella was starting to Legionella likes water sources. It's typically found in outbreaks, like in Austin, there was an outbreak on a very, very popular hotel that's very costly on 6th Street. I'm not gonna mention any name, but you can think about it. And there was an outbreak in Round Rock off of a hotel that's right off of McNeil. And so both of these were because of the shower heads were contaminated by Legionella pneumophilia. If you are going to buy a shower head, buy one that is metal. Do not buy one that is plastic. Because the plastic will allow for biofilms to actually grow, the metals will not, because of the oligodynamic reaction that we talked about in meeting 2. The metals will inhibit the actual growth. Oh, you remember that? Dati said, I just know what I'm gonna write my question about. So if we think about this, it's hard to grow. When the person took the sample and they put it on a plate, nothing would grow, but this person who took that one sample got a little bit of the activated charcoal and it landed in the sample. They took it back and when they put it on the plate, just by fortuitously, by accident, lucky, they got a little bit of activated charcoal and landed on the plate also, and then an organism started growing on the plate they had not seen before. And that organism became known as Legionella monophilia. It got its name Legionella, right, because it was at the French Legionnaires Convention. Pneumophilia, philia means it loves, pneumo, the lungs. That's how it gets its name. In the late 50s, early 60s, there was a fever of unknown origin in Michigan, and they didn't know what it was, and it was causing problems in a clinic, but mostly in the back part of the clinic, where nobody really noticed that there was a different air conditioning system back there, right? The rest of it had a different system, but the back was kind of where it built on, and that was old, it had the old one, and so there was a fever of unknown origin that they called Pontiac fever, Pontiac, Michigan, right? So when Legionella pneumophilia got described and identified, the CDC took samples that they had kept back from back then, and they took those and they looked at the DNA of the organism, of the thing that was causing Pontiac fever and the thing that was causing Legionella pneumophilia, and they found them to be identical. So it's the same organism, just we weren't smart enough to figure it out the first time. It's an underreported infectious agent because a lot of people just think they have a chest cold and they don't go seek medical attention. For most people, especially your age group, it's self-limiting, your body takes care of it, and you're not hurt. But the mortality goes up significantly with older individuals. Okay? Anybody have questions? Okay. Hantavirus. Hantavirus is a zoonosis that is associated with the droppings of certain rodents. In this case, it's the rat or the mouse. Okay? So if you are in a place where there's a lot of mice or a lot of rats, you potentially are going to be exposed to hantavirus. When we first moved into our place in Oak Hill, there was a little shed in the back, and the shed was like a little old-fashioned red barn. You know those cute little red barns you see kind of when you're driving in the country. They're really kind of cool. And I went in there, and it was full of stuff. And like the person who owned the property before we bought it left all this stuff there, and so there was a bunch of junk in there. So I cleaned it all out. And then when I got to the second floor, it was completely covered in rat poop everywhere. My wife poked her head up there and said, I'm leaving now. I said, you're not going to help me? She goes, you're the microbiologist, you can deal with hantavirus. She's too smart. I'm like, okay. So I put a mask on and I swept and it was everywhere. But I cleaned it all up. And then a month later, my wife decided we should tear it down and build a new one. I wish you would have figured that out a month before when I did all this work. But now we have a little shed back there and it's really cool. It's the bottom part of the workshop. The top part is supposed to be like our exercise area. It's now become a library. It's just got a bunch of books and things like that. And it's pretty cool. Right. So if we be careful, we wanna be careful because you can see the symptoms, fatigue, fever, muscle aches, right? And then you develop hantavirus pulmonary syndrome, right? Headaches, dizziness, abnormal problems like nausea, vomiting. A lot of those are due to the sputum that's being produced, and it comes up, and then instead of spitting it out, you swallow it. It changes the pH of the stomach, which causes nausea. Did you have a question?
Do you know if animals can get this? Or dogs or cats?
I'm not too sure about that. They get a lot of other things, so I would say probably they could probably get hantavirus. Okay. So here, remember I told you that the lungs, when they're healthy, they are really black. That person's in trouble. Right? Look at that; it's completely infiltrated. Right? You can see that kind of west United States, central to west United States, we see a lot more cases of hantavirus. Right? I think the people on the eastern side, they don't like mice. Anytime they see them, they kill them. However, I will tell you, if you ever go to New York, it can be a scary place because at night when you're walking around, there are rats everywhere. And really, there are two different types of rats, and I don't know, it's like some part of Central Park, like one population is this way and one population is that way, and they're genomically different, very different. It's kind of interesting to think about how that happened right there. Yeah.
Girlfriend of mine, when we were little, she had, lived in my neighborhood, she had 2 rats, pet rats. Is that also just as dangerous?
No,
that they're...
the pet rats are not gonna be the problem.
Okay.
Because they don't come in contact with the wild forms, and the wild forms are really gonna pick up the hantavirus.
Okay.
The ones that are cute and have little pink eyes and
Yeah.
are white and they run around and they tickle you with their whiskers, no, those guys are not a problem.
Okay.
So, but you gotta be careful with those guys because if you let them out in the yard, the hawks will eat them because they stick out like a sore thumb. Right? Four Corner State, so right here, right, Colorado, New Mexico, Arizona, Utah, you see a lot of cases there. Right? There was a case where kiddos were playing and they were hide and seek, and some of them crawled under a house, and there was a lot of rat droppings on there, and 4 kiddos, 1 died, developed hantavirus. If you don't know what you're doing with rat poo, stay away from it. Right? Hire somebody to clean it for you. Wear a mask. Okay? Questions? Okay, so Pneumocystis jirovecii. It is an indicator, write this down, it's an indicator for having AIDS. It shows up in the last stages of the development of AIDS to syndrome. You don't see it when you're HIV positive, you see it when you start to have failure of the immune response, okay? We used to think it was a protozoan, but we now know it's a yeast, okay? So those are the things I want you to know for Pneumocystis jirovecii. Pneumocystis jirovecii causes pneumonia. It used to be called, we used to think it's a protozoan, but it's a yeast, right? It's an indicator for having AIDS, okay? Good? So let's go to whooping cough, Bordetella pertussis. So Bordetella pertussis is the etiology of whooping cough. It is a little tiny organism, right, that affects the ciliated cells of the lungs and the trachea. So if you think about the ciliated cells of the lung and trachea, they're constantly doing this because they're part of the mucus escalator and they move out all of the stuff of the lungs. Right? If you have whooping cough, if you have Bordetella pertussis show up, it fragments those ciliated cells or inhibits them from doing their job, and now you're not removing the stuff out of the lungs. So you start to develop fluid in the lungs, and this is mostly going to be seen in little kids. Although lately, in the last 5 years, we have started to see whooping cough infections in adults. And by the way, you're all the carriers. You're the carriers of whooping cough. It doesn't really affect you because you've been vaccinated or throughout your entire life you've developed immunity to it. But little kids, right, you can give it to them. Okay? Nobody used to die of whooping cough. People are not dying. It's become more dangerous. Okay? So it's dramatic in little kids, right? Because when they start to have that fluid accumulation, the body wants to get rid of the stuff that's in the lungs, and the ciliated cells aren't working, so they start to develop a cough. And sometimes the coughing spell can last 45 seconds, right, or longer. And that may not seem like a lot of time, but when you're coughing, and you keep coughing, you run out of breath, and then you try to forcibly take oxygen across the trachea into the lungs. And when you're coughing and you're trying to breathe, you develop kind of that whooping sound, and that's how it gets its name, whooping cough. Okay, good. And so it's important for us to understand that here is a young patient who is struggling to breathe because of whooping cough. You can see all of the exertion that's going on in the body. This is dramatic in the case. Yep.
So, how do you, like, if you think your kid has it?
You gotta get it checked out. Do not sit there and think they're gonna get better. Go get it checked out. Okay? There's other things like croup and things like that that kind of mimic it, but nothing has that whooping sound. Okay? This is it. Alright? So, the prevention, of course, is still by vaccination. It's the P and the DPT. Okay? If you don't want to get it together, you can get it individually. You need the D, the T, and P separate. Okay? Cases of whooping cough have been going up, right? And that's because of, number one, people aren't getting vaccinated like they used to. But number two, I think the organism has changed. I think it's become more varied. And so we need,
So it's mutated, I guess.
yeah. And so I think we need to kind of reinvestigate our entire vaccine program. I don't know, maybe they're doing that. Maybe they've done it, I don't know. But it's a problem. And it's become more and more prominent in the population. Okay? Okay. Last organism in this group is Mycobacterium tuberculosis. It is the bad boy of the entire group, by far. Okay, it's a gram-positive rod. Now we don't really call it a gram-positive rod. We like to call it acid-fast. Right? It has a very dystonic type of morphology. It's very rough-looking. Right? It's a chronic infection of the lower respiratory tract of lungs. It has a low-grade fever, chronic cough, tiredness, sweating, and patients who have active TB. When they're coughing, they're constantly shedding the organism just by coughing. Organism goes into the environment. It doesn't die very easily. Because it's got mycolic acid, it can stay in environments for a long period of time. Okay. So it does have kryptonite. It does have the one thing that can kill it immediately, and that's UV. So if you hack out in here and drop it on the ground and it dries, it becomes part of the normal inhabitants of the floor. And if it's real dusty, you kick it up and you can breathe it in. It used to be called, Rachel, an infection of the dusty trades. It's no longer called that. If you're on a subway and you're sitting by somebody who has TB, you could pick up TB, but the probability is very low. It's more likely that if you go to a place where there's people with tuberculosis and you get exposed over and over again, that you could pick it up. If you want to get a good chance of serologic converting to TB positive, get incarcerated for the weekend, right? Because it is big time in jails. In the homeless population, we also see it. Okay, good. So if we think about this, in the United States, the incidence of tuberculosis is about 300,000. Right, so new cases of TB on an annual basis. In the United States, it has a 10% mortality rate. Because we have a lot of infrastructure here, we have anti-tuberculosis drugs we can give. And in some of the rest of the world, in some countries, it has as high as a 75% mortality rate in some cases. Okay? It is one of the infectious agents that is pandemic. The other one is what? What's the other infectious agent that's pandemic? HIV/AIDS. The two. So if you test positive, you have to be further worked up. That doesn't mean, if you test positive, it does not mean you have TB, it just means you've been exposed, okay? And so you we mount a fulminant and huge immunological response to TB. That's what does most of the damage to the lungs, right? So if you look at the lungs, you can see the spottiness of the gone tubercles. This is the TB in the lungs. This is what it looks like when you do a necropsy, an autopsy, and you open up the lungs. That's the damage that can happen because of tuberculosis. You are going to be exposed to TB as a nurse. You're not going to be, maybe not as a dental hygienist, low probability. But as a nurse, you're going to be exposed to it. It's just gonna happen. Okay? They have these cute little masks that look like a duck bill that you can wear that will protect you from being exposed to TB, and they work very effectively. I have one somewhere, I just don't know where. We'll find it. If you work in industry and you can pick up one of those duck bill masks, if you'll bring me one, I'll be happy to pay for it. Okay? Because I know what that is. So let's talk about the two different stages of tuberculosis. There's the latent, when you get exposed and the organism gets into the lungs, and then the body tries to get rid of it, but it can't because of the mycolic acid. The mycolic acid is resistant to phagocytosis. So what happens is the body forms these calcifications around it. We call those gone tubercles. The active is when it's actively growing. So it goes into your body, it becomes latent, becomes dormant for a little while. And then something happens where you're stressed out and the calcifications break apart and the organism starts running actively in your body. So this is an active, these are gone tubercles, right? That's how you spell it, gone tubercles. They're the dormant state of tuberculosis. And then it starts actively growing, and then you have active TB. And so you can see the lower lobe of the right lung here is actually showing an active case of TB. At that, looking at this, without thinking about symptomology, you don't know what it is. It's something. Right? It could be a fungus, it could be a yeast, it could be a bacterium, who knows? But we have to do further workup. Okay? So, you all, on an annual basis in medicine, you will be tested for tuberculosis on an annual basis. And we do that by the TB skin test. We can do titers, but they're more expensive. So the TB skin test is the easy way to do it. There's two ways. You have the time test, which has like 6 little needles and they push it down and then they remove it. Or they can do it with about 1/10 of a cc of the actual tuberculosis pieces and they put it right underneath. That's called a PPD. So you get tested, PPD. If you test negative, you're a happy camper and you go on with your life, you don't care. If you test positive, we have to work you up. And so what we do next is do an x-ray. If your x-ray shows infiltration, you're positive. If it shows no infiltration, you're negative. If you test negative and have no documentation that you've been treated for tuberculosis, CDC recommends a 6-month therapy with the #1 anti-tuberculosis antibiotic, which is asanicil. Okay? If you test positive and you're active, it's a 12 to 24 month treatment, and usually it's 18 to 24 months of asanicil plus one other anti-tuberculosis drug. You'll be taking 2 of them. I would recommend rifampin. The problem with rifampin is that everything that comes out of your body that's liquid is going to be orange. You will cry orange, you will salivate orange, you will sweat orange, you will urinate orange. These drugs are toxic, right? And so you have to test your liver enzymes frequently, monthly, to make sure that your liver's not being affected by the drugs. Okay? You're gonna come in contact with this. It's out there. Okay? Questions? All right, now, when you do the TB skin test, you come back, you get it on Wednesday, you come back in 72 hours, right? And they measure the induration. The induration is kind of a wealth of homes. If the induration measures 8 or more millimeters across, you've tested positive for the skin test. And then you have to be further. Okay? Good? So, There is multi-drug resistant tuberculosis in the United States. We don't have extremely drug resistant TB here, not yet. It's going to come here at some point. It is in Asia, for sure. And India also. And it's really bad. There's nothing we can do with that. The one thing we can do is if you have TB, extremely drug resistant tuberculosis in one lung, we can take that lung out. You have two, you can live with two just fine. You might not run a marathon. Well, who needs to run a marathon, right? You just want to live, right? But you have to be careful after that because you only have one, right? Good? Anybody have questions? There are other organisms that produce tuberculosis-like syndromes, right? Avian, MAC, so Mycobacterium avian unicellular complex. We typically see these with AIDS patients, and it's nothing can cure it. There's no antibiotics that will help here. Which brings up the idea of using phage therapy. Right. I believe we should be using phage therapy already. We have so much drug-resistant bacteria. Let's use a virus to go and kill them. Viruses are host specific, they'll go in there, they'll knock them out, and then they themselves become non-self, and the immune system takes care of them, so they will not hurt us at all. Right. But nobody wants to do that in the United States right now because they believe it's too risky. I guess they watched, I Am Legend too many times, and they think we're going to develop zombies after that. But I don't know, that's not going to happen. But we had tuberculosis beat down in the corner in the 50s, and we had it almost completely wiped out. And then we just, because the government's not very smart, we just stopped putting money into programs, right? We would, now in those days, Harlow, you could test positive and we'll say, oh, Harlow, we want to send you to get better. We're going to send you to a place where there's a lot of sun and you'll be able to hang out in the sun and get better. Because TB, we would say things like, it's allergic to the sun. Well, we'd send you there, right? We'd send you what we call a sanitarium, and you would hang out with a lot of other TB patients. Oh, and you would sit out at the pool and take in the sun all day, right? But we didn't really send you there to get better. We send you there to get you out of population. We did. We could do that back then. We cannot do that now. It's against people's civil liberties. So now we have to rely on people being compliant with taking their drugs. And here's the problem. If you start taking a regimen of anti-tuberculosis antibiotics and you miss one day, you start all over again. Sometimes when we think people are non-compliant, Christy, we might send people over to your house every day to make sure you take your drugs. Okay? My uncle took them, he didn't have to have anybody come over, mostly because the healthcare providers knew that we were there and then we would beat him to a pulp if he didn't take his They taught us, they taught me, my aunt, and my mother how to care for him. And so we would wear a mask. We didn't have a nice day. We would wear a mask, we'd go in there, we would help him. If he started coughing, we would try to leave the room. But he got better. He got cured, which is not what happens for everybody. Any questions? That's the respiratory system in a nutshell. And we still have so much time. We're going to start.